Good morning, sir, ma'am, and miss. My name is Felicity Putri, and I'm going to present what I've learned this week. Cleft lip is an aesthetically unpleasant congenital orofacial deformity. The least common type of isolated cleft lip is bilateral isolated cleft lip. The most common method for bilateral cleft lip is the Mulliken's and Manchester repair. There's a challenge in performing bilateral cleft lip repair, which is anticipating the four-dimensional changes of the growth and distortion. When performing bilateral cleft lip repair, the restoration of the nose involves the skin, cartilage, and mucosa of the patient. Bilateral cleft lip repair needs some markings, such as philtral mucosal flap, supine procision or draft, philtral flap from columella edges, and vermilion including the white roll bilaterally. When doing the bilateral lip complete dissection, the columella will be augmented from the philtral skin. We should see the symmetry of the nostrils and the alignment of the columella in the patient's face on the post-operation of complete bilateral cleft lip repair. The anatomic consideration of abnormalities are abnormal attachment of orbicularis oris, Cupid's bow, vermilion, philtrum, alar nasi, nasal floor, nasal bridge, alveolus, and maxillary hypoplasia. The best time to repair unilateral cleft lip is when the patient is 3 months old, weight above 4.5 kg, and hemogram more than 10 gram per deciliter. The pre-surgical considerations are pre-surgical orthopedics, nutrition, infection prevention or control, growth and development, and exclude cardiac anomalies. Meanwhile, the operative considerations of unilateral cleft lip are identification and markings of anatomic landmark, preemptive hemostasis, detachment and mobilization of orbicularis oris, repair of alveolar soft tissue, incision and raising of flaps, hemostasis, and tension-free repair. Last but not least, the post-operative considerations are adequate analgesic, dressings, and handlings of sutures. Notching, labial asymmetry, wound complications, oronasal fistula, and scar complications are the example of the complications and outcomes. There are some future treatments, such as secondary surgeries that may require lip adjustments, alveolus, and nasal deformity. The wound complications can be complete or partial dehiscence. The recovery time after surgery usually requires several weeks of special care. The failure of fusion of palatal shelves called cleft palate. The palatal fusion happens in 5 to 6 weeks intrauterine. So the ideal time for surgical correction if the cleft palate is formed alone is between 9 to 18 months postnatal. Meanwhile, for cleft lip and palate is between 3 to 6 months. The problem with submucous cleft is soft palate may not function normally. The priorities of palate repair are closing the defect, making the palate work in anatomy and mobility aspect, and minimize the sequel. Meanwhile, the principles of the palate repair are repositioning the muscle, separating the components, displacing them medially, and approximating in the middle. The most important artery to be lifted along the oral mucoperisteum procedure is the greater palatine artery. Cleft palate surgery should be performed for patients 6 to 18 months old and not more than 2 years old. When doing a cleft palate surgery, operators should pay attention to some stuff such as anesthesia, mouth gag, communication between the surgeon and anesthetist, and the color of blood from incision. The important muscles for cleft palate surgery are levator veli palatini, tensor veli palatini, and palatopharyngeus. There are 4 procedures for cleft palate surgery: von Langenbeck, flap palatoplasty, VY pushback palatoplasty, and Furlow's double opposing ZZ-plasty. The third procedure, VY pushback palatoplasty, is not suggested to be performed on children since it may affect the growth of the face. Greater and lesser palatine vessels are the most important blood supply during cleft palate surgery. Cleft palate can be syndromic, which divided into non-isolated, which is associated with additional structural abnormalities or associated with a known genetic etiology. Submucous cleft palate is divided into overt and occult types. The classification of cleft palate is divided into 4 classes. There are 6 muscles of soft palate: tensor veli palatini, levator veli palatini, palatopharyngeus, palatoglossus, muscular uvula, and superior constrictor. The connection between the tongue and the uvula called palatoglossal arch. Variation in number, shape anomaly, enamel defects, and dental caries are the example of dental irregularities on patients with cleft palate. The goals of surgical treatment are to have proper speech development, adequate growth maxilla, improve auditory function, and prevent fistula formation.